Good evening, doctors. And it's my proud privilege to be a part of the CardioCon 2022. And I will be sharing my slides and I will be talking about my topic today. My topic today is emerging therapies in lipid management. And I'm very thankful to the team CardioCon 2022 for giving me this opportunity to talk about the emerging therapies. Now, why are emerging therapies important in dyslipidemia? Why is there a need for new therapies? Studies have shown benefits with statins in both primary and secondary prevention of atherosclerotic cardiovascular disease. There has been a relative risk reduction of 25 to 40%. However, many individuals continue to have ASCVD events despite statins and despite optimal level of LDL. Therefore, we need newer emerging therapies to reduce LDL further, to reduce apolipoprotein B containing lipoproteins, to reduce LP little a or lipoprotein little a, which has emerged as a very important risk factor for ASCVD, both primary and for secondary ASCVD. Now, also to reduce events in patients with high triglycerides and to target inflammation to reduce ASCVD risks. So today I'll be talking about some of the currently available as well as the investigational non-statin medications for dyslipidemia or hypercholesterolemia. I'll be talking about the cholesterol absorbing inhibitor ezetimibe. I will be talking about the PCSK9 inhibitors. I will also talk about bempedoic acid, and I will be talking a little bit about inclisiran. So basically, what are RNA and gene therapies? This is very interesting. Patients with untreated lipid disorders carry a very severe risk of cardiovascular disease. To achieve better treatment outcomes, novel selective gene expression and epigenetic targeting therapies are being developed. And in my subsequent slides, I will be talking about such therapeutic innovations which are employing targeted RNA technology. So let me tell you that these are the drugs I'll be talking about. So coming to ezetimibe, there has been a very interesting trial on ezetimibe called Improve IT. What was done in the trial is that patients who had had an acute coronary syndrome, within 10 days of the ACS, they were classified, they were divided into two groups, the conventional group and the interventional group. The standard treatment where simvastatin 40 milligrams was given, irrespective of the LDL numbers, which could be between 50 to 125 milligram%. And in the other group, which was the interventional group, we gave ezetimibe plus simvastatin. So two groups, one receiving simvastatin alone and the other simvastatin plus ezetimibe. And after follow-up, and the duration of follow-up was for about 2.5 years, it was found that the primary endpoint of cardiovascular death, myocardial infarction, stroke, heart failure, hospital administration for unstable angina, as well as coronary revascularization were all less in the group receiving both simvastatin and ezetimibe. Again, benefit of adding ezetimibe to statin therapy on cardiovascular outcomes was more in patients with diabetes in the Improve IT trial as compared to the non-diabetics. So the diabetics benefited more with greater reduction of events as compared to non-diabetics. Probably the reason being that absorption of cholesterol from the diet is more in diabetics as compared to the non-diabetics, and therefore ezetimibe may be more effective in patients who are diabetic. Over and above statin, they may help to reduce cardiovascular risk. Now, coming to the role of PCSK9 inhibitors, doctors, we have been using this in our hospital, Gangaram. I have been a part of the trial. Now, very simply explained, there are LDL receptors on the hepatocytes. The circulatory low density lipoproteins, it attaches itself to the LDL receptor on the hepatocyte. This LDL receptor complex, what this is actually now PCSK9 attaches to it, right? So what is basically PCSK9? It is also known as pre-protein convertase subtilisin kexin type 9. This The entire complex of PCSK9, LDL, and LDL receptor is then internalized by the hepatocyte. After internalization, it is destroyed by the lysosomes, and now the LDL receptor is destroyed. But if we could somehow block the PCSK9, then the PCSK9 LDL receptor complex will not be internalized and destroyed, and more number of LDL receptors will be available to come back to the surface of the cell, that is the hepatocyte, and carry more LDL inside. So this is a very interesting group of drug because PCSK9 blockers are basically monoclonal antibodies, and we are using two of them. I will subsequently in the slides show you the trials of the two of them. Now, this is very, very interesting that once the LDL receptor number increases, more LDL receptors are available to catch the LDL from the circulation and bring the LDL inside, where of course the low density lipoproteins are then metabolized into fatty acids. So this was the trial with evolocumab, the clinical efficacy, effect on other lipid parameters compared to placebo. So see, statins may not decrease consistently other proatherogenic lipid parameters, and they may not increase the HDL as much as evolocumab. So evolocumab decreases apolipoprotein B, it decreases LP little a, it also decreases VLDL cholesterol by 30%, and it may increase the good cholesterol or high density lipoprotein cholesterol by 5 to 9%. Now, these were the two trials. The Odyssey trial, this was the Odyssey trial, it was in 57 countries. And again, in the Odyssey trial, it was found that when you use the evolocumab, there was a reduction in LDL to even lower levels that you could achieve with statins alone. So here you can see that on patients on treatment with the PCSK9 inhibitor, this drug, there was a reduction in all-cause death, further reduction in even the primary endpoints was seen, which is non-fatal MI, non-fatal stroke, and hospitalization for unstable angina or requirement of angioplasty. Now, again, there's another trial called the Fourier Trial. In this, further cardiovascular outcome research with PCSK9 inhibitors in subjects with an elevated risk. Huge number of patients was screened, and then they were given evolocumab subcutaneously versus the other group which received only placebo. And again, it was found that there was a reduction in the primary endpoint as well as the key secondary endpoints, with a 59% mean reduction in HDL in LDL as compared to statins group, which means a placebo group which had only statins. So again, safety wise, very safe drug. CV death, MI, stroke at the end of LDL, and the LDL cholesterol levels at the end of 1 month. You can see months after randomization that there is a reduction. Now, so PCSK9 inhibitors are now in a big way. We are using them not only in patients of atherosclerotic cardiovascular disease to avoid a secondary event, we are also using in patients of familial hypercholesterolemia. We have been using it in patients of heterozygous severe familial hypercholesterolemia. I have used it in Gangaram. So in these patients, more than 50% of the LDL receptors are absent. So they're less in number. So if the LDL receptors are less, obviously less LDL can be taken from the circulation and internalized. So by using PCSK9 inhibitors, we can block the PCSK9 so that the LDL receptor complex is not destroyed and more LDL receptors are available to bring the LDL inside. Now there is another oral anti-lipidemic drug called bempedoic acid. Again, this is oral. Again, it is a non-statin drug. And what is the mechanism of action of bempedoic acid? So this is very interesting that bempedoic acid does not act where HMG-CoA acts. It acts at a higher level. So what bempedoic acid is available as a prodrug, then it by the enzyme ACSVL1, it is converted to active bempedoic acid, the drug itself. The advantage is that ACSVL1 is only present in the liver and it is not present in the skeletal muscle. So bempedoic acid does not cause many side effects on the muscle. So it causes lesser side effects on the muscle as compared to the statin. Now, how does bempedoic acid work? It blocks cholesterol, this biosynthesis in the liver. It inhibits ACL. So this ACL is adenosine triphosphate citrate lyase. This enzyme is upstream from HMG-CoA. You can see it. It is upstream from HMG-CoA. And therefore, what happens? There is also LDL receptor upgradation, more LDL receptors. And again, the same thing, more LDL receptors means more LDL is trapped. More LDL is trapped inside the hepatocytes. Therefore, the plasma LDL cholesterol decreases more. So this is an oral non-statin drug, which is still experimental and we have not used it yet. Now, this is the efficacy of bempedoic acid, pooled analysis of 4 phase 3 trials. And there's also a combination of bempedoic acid and ezetimibe, which is available. And so if you summarize, it inhibits ATP citrate lyase, inhibits hepatic cholesterol synthesis upstream of statins. It decreases LDL-C, then 25% in statin naive patient. And if you give it to a patient who's already on statin, there is an additional 18% reduction in the LDL levels, right? So well tolerated in individuals with statin intolerance. This is the biggest advantage because it does not cause any myalgias and therefore, but it can be used in patients who cannot tolerate statins because of severe myalgia or myositis. Then small increase of uric acid, but there's a signal for improved glucose tolerance. And it may also decrease HSCRP. So it also has, bempedoic acid also has an anti-inflammatory effect. And now we know that ASCVD may be related to inflammation. Now coming to another new class of drugs known as inclisiran, again, very interesting drug because here what we were talking about, the targeting the RNA, right? So this is targeting the, what we do is basically inclisiran is a small and it is small and it is interfering double-stranded RNA. And what does it do? It silences the messenger RNA in the hepatocytes and prevents translation of PCSK9. So again, PCSK9 is not translated and therefore PCSK9 cannot, block the LDL receptor complex, which is destroyed by the lysosomes. So because of non-translation of PCSK9, there will be inhibition of production of PCSK9. And therefore, this drug is again a very powerful drug to lower LDL over and above the reduction seen with statins. And it also lowers Lp(a). There were 2 trials on inclisiran, the one in America called the Orion 1 and one in Europe called the Orion 2. To summarize the trial, inclisiran is given twice a year as an injectable therapy. It lowered LDL-C by greater than 50% very safely from baseline. So Orion 2 met all its primary and secondary endpoints. It reduced the primary LDL-C endpoint by 54% at 17 months and 50% time averaged. Inclisiran resulted in potent and a consistent PCSK9 knockdown. And inclisiran achieved durable and potent LDL-C reduction with only 2 yearly injections. So you just have to give 2 injections. Of course, they're very costly. There are not many side effects. Safety profile similar to placebo. And of course, there have been some injection site events. There can be some itching and some reaction. All right. So this is, then I'd like to talk about the reduce IT trial. So we come now from inclisiran, now we come to omega-3 fatty acids. So we know there are 2 omega-3 fatty acids, epoxypentoic acid and docosahexaenoic acid. Now, omega-3 fatty acids decrease triglycerides and VLDL, but the effects are seen with high doses, greater to 2 to up to 4 grams per day. So this was the trial known as reduce IT. This trial evaluated the use of icosapent ethyl. So IPE is a highly purified EPA, either in patients with established ASCVD or patients with type 2 diabetes with 1 or more ASCVD risk factors who had persistent hypertriglyceridemia in spite of giving them maximally tolerated dose of statin. So these were patients who were identified. They were given maximally tolerated dose of statins. They had good LDL levels, but they had very high triglycerides in the range of 135 to 499. So this trial was carried out for a period of 5 years, and it was found that when you gave IPE or icosapent ethyl to patients, there was a reduction in pre-specified ASCVD endpoints, both fatal, non-fatal MI by 31%, fatal and non-fatal stroke by 38%, cardiovascular mortality by 20%, and in reduced IT, the net triglyceride was reduced by 15%. So we do have these omega-3 fatty acids, which can be used, of course, in a dose of 2 to 4 grams. Now, this is the algorithm to manage hypertriglyceridemia. We have to remember that main target is LDL. Then you calculate the non-HDL. You assess the ASCVD risk. Lifestyle intervention is important. A low-fat diet, avoid refined carbs, more complex carbs, weight reduction, exercise, less alcohol, no smoking. All these, of course, we have to control type 2 diabetes. But if the cholesterol is more than 500, and there is an increased risk of both pancreatitis and ASCVD, then we can give a very low fat diet, weight reduction, all that. Along with that, you could give either fenofibrate, or now after the reduced IT trial, you can give omega-3 fatty acids. And of course, in our country, we do give saroglitazar, and I'll be talking briefly about it. So this is another new drug called pemafibrate. It is a novel selective PPAR alpha modulator with higher potency and selectivity for PPAR activation, PPAR alpha activation than even fenofibrate. Now, the available preclinical and clinical data suggests that this new drug, due to its favorable benefit-risk balance, is more effective than the conventional PPAR alpha agonist. Now, the drug that we are using, saroglitazar, is a dual agonist of both PPAR alpha, thereby taking care of hypertriglyceridemia, and it's also a gamma agonist, thereby taking care of some amount of blood sugar. Fibrates are, of course, PPAR alpha agonist, and this is a new fibrate, pemafibrate, which is an even highly potent PPAR alpha agonist. Now, of course, we know that thiazolidinediones are PPAR gamma agonists. Now, after a quarter of a century of treating LDL cholesterol, we realized after these studies that high is bad and statins were needed. And statins decreased both primary atherosclerotic cardiovascular disease and also protected from secondary. But still there was some risk. Then it was found that average is not good. We need to lower it even more. After trials, we found that even lower is better after the improve IT. And after Fourier and Odyssey, it was found that if you take the LDL even to as low as 20, you still found cardiovascular benefits. And Fourier and Odyssey were the two trials with the PCSK9 inhibitors, evolocumab and the other cumab, right? So to summarize, I have not talked about the anti-inflammatory agents. We have lots of them. We have colchicine, methotrexate. We have other studies on various other drugs. Since I have little time, I will summarize to say that the development of novel RNA-based therapeutics and viral gene therapy is providing more specific and potent therapies for tackling complex and devastating lipid disorders. The other thing is, doctors, we must do an extended lipid profile. We must check the LP little a. We must do the apolipoprotein A and capital A and B. And we must remember the other lipoproteins. We must target not just LDL, but non-HDL, also triglycerides in diabetic patients who, in spite of full dose of statin, maximally tolerated dose of statin, still have a high triglyceride, may have residual risk. So the gist of my topic is that newer therapies can address residual risk of ASCVD in patients who are already on dose of statins. We have several drugs which are in phase 1-3 of development, and several novel therapies are being explored. And lipid metabolism is very complex. It's a multifactorial system, and therefore the side effects of different gene targets have to be considered. Thank you.